So good morning. First of all, I thank the organizers for this opportunity to start with this conference, with this speech. And actually, I'm very impressed with the achievements so far of this conference. I have been only here for the last 3 times this conference was organized, and I think it's a very nice size, first of all. I hope it doesn't grow as big as, for instance, Society in Oncology, because it may be too big to really get into touch with people. I have seen a lot of collaborations between people in this conference already. Actually, we are taking part in collaboration with some groups, and also what I like very much is the mix clinical studies, trials, if you like, in the future, and the basic sciences. So now, Marion nicely addresses me as her colleague. I'm not a radiologist, I'm not a clinician, I'm an MD, but I'm a pathologist, I'm a neuropathologist, if you like. And so the title of my talk, attributing patients to trials, is a little bit not my cup of tea. So what I will do is give an overview, and I hope to stimulate creative thinking in this field of cerebral metastases, because I think there are so many aspects. It's a complex topic, and there are so many aspects that are still not really thoroughly being addressed, specifically either in the basic sciences. So incidence figures may vary from country to country, etc., etc. Let's just conclude that there is some impact on therapies nowadays for specific cancers that may have an influence on the incidence of cerebral metastases, and that's one thing. And let's go basic a little. We know from clinical observations already, and you all know that some tumors have a predilection for the brain, in a sense, and others will try to avoid the brain. I mean, a prostate cancer rarely goes to brain, whereas a lung cancer really loves brain. And why is that? There's so many things we don't know yet. Clinical context. I don't know how many clinicians are in this audience. I don't know how many basic scientists. But I mean, in a clinical context, of course, you were in a situation, if you want to treat a patient, you either the primary is known, and if the primary is known, you need to know whether there are other metastases than only the cerebral metastases. Patients can present with the cerebral metastases at first. The primary actually may be unknown, a very difficult situation. The carcinoma of unknown primaries. There may be patients with more than one primary, which is a complex situation, I guess, for clinicians in particular, and treatment choices. And again, the primary tumor may be under control, not under control, and there may be solitary metastases or multiple metastases. So we have a variety of situations, and I think that will complicate the accrual to trials particularly. But fortunately, I'm not a clinician, so I will not face that. But I try to feed from basic sciences and translation research, maybe more data, and not only me. I think particularly the young generation should do that in the coming years. Leptomeningeal metastases, so carcinoma, meningitis carcinomatosa, is of course a specific situation in which cancer cells are actually in the CSF. The diagnosis of that is, from pathology side, pretty troublesome usually. That's why we had all kind of endeavors already in proteomic profiles of the CSF and to trace, actually to find traces of cells that we couldn't see through the microscope. But anyway, this is a particular situation, and leptomeningeal metastases may go along with intracerebral metastases or not, but it is a different situation. It's a different compartment that we are facing. When we go back to carcinoma, just to the tumors themselves, I mean, to be able to metastasize, tumor cells need to be in the circulation. That's one thing. How they come into the circulation is another thing. There's dissociation of tumor cells from a primary, or maybe even from a metastasis. And so these tumor cells are floating in the circulation, and one way or the other, they know to transgress the endothelium of vessels where they are, and they're in the circulation. There will be all kind of interactions, mind you, with I think immune cells and whatever, and then they have to go out of the circulation at some sites, and particularly in the brain, they have to pass, if they are in the circulation, the blood-brain barrier. But the situation is even more complicated than that, because we do not know so much about the blood-brain barrier. If you really dive into the basic literature, and this is another call, basic research specifically to the blood-brain barrier, or the cerebral vessels, if you like, is, I think, urgently needed. But there's not only a blood-brain barrier, there is also a blood-CSF barrier. There is a choroid plexus hanging in the CSF, which contains, of course, vessels, and they have a barrier with the CSF. And, of course, the ependymal lining, choroid plexus being a specialized type of epithelium, basically, of a special type of ependymal cells, if you like, also producing CSF. Also, there's an ependymal CSF barrier. All these barriers need attention, I think, when we talk about cerebral invasion of tumor cells. I can talk about this perhaps next year. We are doing some microdissection of BBB in Rotterdam now and do proteomics, and we find proteins that have never been described in the basal lamina of the blood-brain barrier. And so just to tell you that there is a lot unknown. Are there age effects? Are there effects of the specific site of the BBB? So interaction of tumor cells with the BBB is complex because we don't know enough about the BBB. There are a lot of molecules involved in the blood-brain barrier, talking about the blood-brain barrier again, transmigration. And so I listed a few here, but this is, of course, a growing list of molecules that act at different sites and act on maybe they're expressed by the tumor cells themselves, maybe they're expressed by the BBB itself. I mentioned specifically for the brain the 5T6 GalNAc5 that came of the group of Massaguet, which was really a molecule that was described as being specific for cerebral invasion of tumor cells. And last but not least, let's keep an eye on the immune system. And immune cells, what are they modulating to maybe play a role in either modulating the BBB to make it more permeable for tumor cells, or maybe have an effect on the tumor cells. Okay, so once in the brain, or transgressed through the BBB, these tumor cells will find themselves in the perivascular spaces. Now there we have another issue. What is a perivascular space, actually? This just across the BBB, but there is also, probably from your med school, if you have ever studied thoroughly, I mean, you have these Virchow-Robin spaces, which is an extension of the subarachnoidal space along the vessels, and at some point there is a transition where that stops and the quote-unquote BBB starts. We don't know much about that, actually, in anatomic perspectives, how exactly that looks and where one barrier stops and the other starts, etc. So when tumor cells are around vessels, they may still be in the subarachnoidal space. Either they really are further intracerebral and they're around the vessel somewhere, and they may be dormant for a while. I appeal here the work of Frank Winkler from Heidelberg, who did really great studies on this, specifically this niche, being actually lung cancer tumor cells being in that position, and how they further signal to grow out into the brain tissue. And now there are quite a number of factors, or I think many factors that really will influence whether these cancer cells will actually further invade the brain, or they stay around that vessel. For how long, we don't know. We can't visualize that yet. Maybe radiology in the future can visualize dormant cells around the vessels in the brain. I don't know. And there's another relation, that's with angiogenesis, because when these tumor cells start to proliferate, at one point in time they will need vessels, blood vessels, and so they have an impact on pre-existing vessels. Maybe they create new vessels themselves. We don't know anything about that, but it's all topics that are now being addressed in the literature gradually, I would say. And again, as I told you, this is an adenocarcinoma somewhere in the brain. You see some infiltration around that lymphocyte site. What is exactly the crosstalk between these tumor cells with, for instance, microglia, with TAM, so tumor-associated macrophages, with vascular cells like EPCs, with many subtypes, with stromal cells, as you like stromal cells, astrocytes, I would say. And last but not least, again, the immune cells. So there is a lot to discover the influences. Once growing out in the brain, you can try to distinguish all kind of patterns, which I think usually are not specific for a tumor or something like that, and are not specific within one patient, but are coexisting with each other in the same brain. And so tumor cells may spread along the perivascular spaces because they seem to like that, and not really going further into the brain, but they may also infiltrate the brain, and they may, for instance, disseminate along the ventricle walls, etc., etc. Talking about therapeutic targets now, so there's a lot of basic science that we still need to further develop and do. There's a growing list of targetable molecules for primary tumors. You know that much better than I do. And the TKIs, for instance, recently, I mean, that recently is not so recently anymore. These organic drugs, they are now being used for patients. How representative is the primary tumor if we talk about the metastases, and particularly if you're talking about cerebral metastases? So there have been quite a number of studies in which people do really molecular comparisons between the primary and the metastases. And there may be not such a similarity that at first glance that you would expect. There may be a dissimilarity. And how do you address that? And are they targetable molecules in the metastases, specifically in the cerebral metastases, to treat? And are they in all cerebral metastases then, or only a few? Is there an inter-metastases heterogeneity as well? We don't know. So, for instance, the lung cancer, we know there's a very short list. There are many more targetable, more targets now to list. But again, is this present in the? If these targets are present in the primary, are they also present in the metastases? For melanoma, you all know the BRAF mutations that you can target, not always present in all melanomas, and not always. Perhaps not always present in all metastases. The breast cancer, you know, we address the ER/PR status, for instance. We had to now we can address. But is that therapy sufficient to also address the intracerebral metastases? And there's an issue of sensitivity, of course, to this drug, but also an issue of penetrance of these drugs to reach the intracerebral site of the tumor. So, for instance, and I'm much obliged to Riccardo Soffietti, who's one of my partners in part of the research we do, and he comes with these issues, like, for instance, in breast cancer also there are agents against HER2, but they do generally not cross the BBB, but in combination they may, and also radiotherapy may destroy the BBB, so the penetrance of the drug is better. This is actually pharmacological issues, but they are, of course, extremely important for the treatment of these patients. So agents may have an effect on the tumor cell fraction that has the capacity of crossing the BBB. Now, again, focusing on the primary tumors, I think there's a lot to win as well. What are the predictive factors of primary tumors, or in the primary tumors, as to the formation of cerebral metastases? And this is one of the topics that we have studied, and actually is a fruitful collaboration now with Manuel Valiente in Madrid. He translates what we find in translational sense in his mouse model, and this is really exciting and great to have that kind of collaborations. And actually we see, and Ruud Pedrosa, my PhD students, will talk a little bit more about that tomorrow, how T cells actually may have an effect on the primary tumor cells, insofar they imprint and induce a changed expressional profile, among which are molecules that, at least in vitro, are upregulated and seem to make tumor cells pass the BBB. Think about the consequences for therapy. Think about the consequences for immune therapies that are being used already. And what are the pluses and the minuses of these therapies, and what are maybe the consequences. So, recommendations now, we'll conclude with that. There are a couple of things here, issues that I don't need to tell clinicians, especially not clinicians who conduct trials for ages, and I mean, they know you have to develop homogeneous and well-defined response criteria. That's one issue, I think. And there is an identification issue of patients at the risk for developing brain metastases and how to go along with that. do not only focus on, in the more future, on intracerebral tumor, but also on eventually prevention of tumor cells crossing a BBB or any other compartment of the CNS to cause trouble and really affect the life expectancy of patients. Investigate chemoprevention. That is not particularly my field, but I mean, what kind of drugs may really prevent the formation of act probably on circulating tumor cells and prevent them to invade the brain. And again, there is the immune system, which is, I think, a major issue now. So I will conclude with one cri du cœur de Français, that is, we really need basic sciences. And of course, basic sciences may be fed by clinicians and by clinical trials, etc., but there's so much unknown in basic science. In my country, anything that you want to have funded needs immediately a translational or an effect on patients. This is insane. You need basic sciences, and we need to cross-talk with each other, basic scientists, pathologists, whatever, with clinicians. But please realize that without addressing the right things in basic science and step-by-step progressing, it gives an essential input in anything that you later will do in the clinic. On the other hand, of course, any clinical experience is highly important to feedback to basic scientists, any observation to translate into basic models. So focus qualities of the port d'entrées of the tumor cells, I mentioned that already, and characteristics of invading tumor cells and their interaction with the surrounding. So that is what I, as a humble neuropathologist, would like to say this morning. Thank you very much.
Well, welcome, and I also like to support what Colin said. This is a, I think, well-established meeting by now, and I think it gets together all people who are working on brain metastases, and I'd like to see it grow and maintained, and I think it's a very good forum. They're not a sideline to ASCO, as a sideline to another big meeting. So it's easy to follow that talk because your cri du cœur, we need. You wanted to work with your basic science needs tissue. So that's why we're here as neurosurgeon, because you need science, but science needs tissue, so that's why we're here. So it's from the problem of metastases, it's a vast problem. It's far exceeding for neurosurgeons by now glioblastoma and its sheer size and number. So the numbers are really amazing, and it's highly complex because not only will will different tumor types sort of determine whether people get brain metastases, but also the therapies may select in the therapy what kind of metastases will develop. The basis of our neurosurgical problem is that most systemic therapies are insufficient. It's nice there are so many approaches and so many attempts, but basically many of them are for brain tumors or for brain metastases insufficient. I think we're all aware that neurosurgery is just a part. It's embedded in a comprehensive oncological concept. But whereas the subspecialties, they will deal with their tumor entities and sort of go in depth. We have to deal with all these tumors. So we get, if we talk about 50 brain metastases, we probably talk about 50 different biologies. Same with the radiation oncologist, and the neuro-oncologist then puts it apart again and does clinical trials for melanoma or for breast cancer or whatever. But this is sort of the bed where all these tumors sort of collect. That's why it's also difficult to have guidelines for brain metastases in general. So I think this is a very nice attempt by the IANO, and they look at all different aspects of it, chemotherapy, radiation therapy, but also surgical resection. And I think these are very important sentence. Surgical resection allows them, for a majority of patients, an immediate relief of symptoms of intracranial hypertension. And then, of course, there's always the thought of including surgery and SRS as an alternative. As many trials are not really very informative, at least the combination of surgery and whole brain therapy seems to be a very well-established concept. So Why would we do surgery for brain metastases? We have to decompress, we establish a diagnosis. As very often 20% of cancer are non-primary, we want to have local control. It's a preparatory measure for further therapies. We want to assess the tumor evolution. And any 2 or 3 of the above will lead to this. For you, this is an example. This is a very unusual lesion. You never know what you have to expect. And it turned out to be an endocrine carcinoma, for which there was quite a good therapy until 2013. When she, after 5 years, eventually died from her disease. And in between, she always came back. This is a local control from the beginning. Then she had this lesion, and which was symptomatic. She wanted to have that taken out. Then this was a lesion we knew that had hemorrhaged acutely, and she wanted to go on a trip, and she had a hemiparesis, a weakness, I should say. And she wanted that out, and then she could, afterwards, she could go on that trip, and then she died later in the year. But you see that this skull looks quite badly treated, but this is it. I mean, we have to go along with the patients and do individual decisions. As in a case like this, that had profusely metastasized, nobody knew what it was going to be. It turned out to be metastatic melanoma, and just with simple, not immunotherapy in the beginning, but standard chemotherapy, had a 2-year course of remission with this kind of picture. So you never know what you're having. This lady gave birth 4 weeks prior to having a seizure. And I went to her and was absolutely certain that this was choriocarcinoma, which I've seen twice. Massive edema, massive contrast enhancement, after giving birth. Turned out that this was a very unusual benign lesion. It was an angiofibroma, possibly. Our pathologists still don't know what it is. It was very rubbery. You couldn't even have biopsied it because your biopsy needle would have sort of gone past it all the time. And you wouldn't have had a diagnosis from a tiny piece of tissue, and they even could get a diagnosis from this piece of tissue. And if it had been irradiated, it would have been a non-radiation responsive lesion. So I think tissue is always a big issue here, not only for basic science. And if we see a lesion like this, we always think, well, this is, of course, glioblastoma. But when you have a patient that had 1 year past colon carcinoma and has a lesion like this, you would not suspect that this is glioblastoma, which it was. This, of course, again, is a little irregular. You would think that could be glioblastoma. But then when you have this, what else could it be other than lymphoma or multiple metastases? Also, this is glioblastoma. So tissue is always a major issue when we see, even if it's multifocal. We should not just from circumstantial evidence think that we know what the diagnosis is. Lymphoma is more or less clear when they go away with steroid therapy. And these periventricular fuzzy edges, this is also most likely lymphoma, which can be proven by biopsy. So let's get back to the metastases. This is what we very often face, and there's no question that this is a surgical case because it's too big for anything else. These have already been mentioned, these trials, Pachel, that there is benefit in combining surgery and whole brain radiation therapy. What we want to achieve with surgery, at least, is local control. And this is always easier when we take out a tumor as a whole, in toto, and because then we don't even injure the tumor, and we have sometimes even little margins of normal brain tissue, edematous white matter around it. So that can give to good local control. And sometimes we can even compare a lesion that goes to radiosurgery and a lesion that is removed. I think what I always think the advantage of surgical removal is that immediately you get the resolution of the edema, which takes a lot more time when you do radiosurgery. And then this, for example, would a very difficult lesion for anything other than surgical, even for surgical resection. It's because it has such a big surface, it's difficult. But with those, you can get a good local control, which sometimes lasts a long time. Like with this cystic lesion, if you can really really peel it off, you may get a control together with whole brain therapy for sometimes years. The question about radiosurgery or surgery plus whole brain therapy was already addressed quite early. Jörg Ton, our group, did that, and it's interesting that for local control, you get a much better control with radiosurgery than with surgery and whole brain therapy. But for distant control of the disease, surgery and whole brain therapy seems to be better than just radiosurgery for a lesion. So this has been taken up in a very recent paper. There's a lot of discussion about this right now because it's just a few weeks old, a few months old. A large trial, single institution from MD Anderson. They looked at patients who had up to 3 metastases, which all could be removed completely, and followed them with radiosurgery or just watched them. And I think this is a very interesting result, because in the group where they had followed the complete surgical resection with radiosurgery, they got a much better local control. So this is the endpoint was reappearance of new lesions at the site of the original tumor. But this is overall survival of the patients. So I don't know what that means. That means that those patients who have worse control have longer survival. So I think one would have to look very, very carefully at these. That's why there's a lot of discussion about this. But I think it's a very interesting paper. And there's even a question in one of the editorials, would that be a new standard, do complete resection followed by radiosurgery? If you see this result, it should be. If you see this, it's questionable. So very often, in this trial included that, we have multiple lesions, and can we go for multiple lesions? Yes, we can. There are very few reports on this, but this again shows you the dilemma of our surgical situation. They went for many multiple keyhole craniotomies, nice surgical pictures in there. So they even have 4 craniotomies that they did at the same time, but you see the original tumors are quite heterogeneous, but still they do get quite a good survival. They get, even with these multiple lesions here, they get 31% at 18 months. If we had that for most malignant glioma trials, and it's not too bad. So as I said, of course we can do that. If they're in both hemispheres, this is and close by, we go first on the one side and the other side, could be one position. Even here, in an 82-year-old lady, just recently, first with the temporal and then do the posterior fossa. She did wake up within a few hours, so that's why the young doctor in the ICU did a CT scan, so that's why we have a 4 hours post-op CT scan. We see that these lesions are completely out and she's now fine. So, but even here, this patient, again, two lesions that had to be gone to with 2 separate craniotomies and a posterior fossa lesion. At the same time, he wanted all this out. This was it's a germ cell tumor, not a very nice tumor, and he had whole brain radiation also, and he developed a new lesion. Didn't want to have his time compromised again by like a 8 or 10 day hospital stay, so he had radiosurgery. And this is sometimes what we see, that we stand there, should we go back in or not? Is that just the reaction that this tumor in this brain, because they're all different histologies, there's nothing general, it has, and eventually we went in and it was just deteriorating tissue from radiation necrosis. So that happens. So the other thing I told you, surgery is for decompression. I think there's no doubt that cases like this need to be decompressed. There's no tumor board alternative or no philosophy that the test has to come out. Same with tumors hemorrhage. Most frequently that's melanomas. So you see large hemorrhages, and in routine here you see the core of the tumor, which can sometimes complicate the surgery in a way that we have fuzzy edges because the tumor is sort of bursting and it's sort of spread all over the place. So this patient was also followed by, back. This patient was also followed by radiosurgery, and eventually we removed the necrosis. So the question is who when gets a radiation necrosis and what to do there and what to do then when they get it. It's fortunately a very rare event, but here again there is a place for surgery if it's positive, if the image is positive for tumor by whatever means you have, surgery of course, but also if the therapies that you think you can give then at this point fail, it would be tissue, and then followed by, in our case, we would always give bevacizumab now for radiation necrosis. So the question always with surgery is what are the complications, and has that to do with surgical technique? The complications, whether you take something out in toto or whether you move it piecemeal, seem to be in favor of piecemeal resection. So there were less complications with piecemeal resection because you're just sort of reducing the tumor and get carefully to the edges, whereas otherwise you sort of manipulate the edges, and if they are eloquent brain, then you have more complications. On the other hand, if you remove tumors in toto or en bloc, you have much less patients who over the course of the disease will develop leptomeningeal spread. I think that's a very important issue to take into consideration. And like here, we had two occipital lesions that we were able to remove in toto, and 3 years later, the patient then developed from a tumor that, when we looked at it, was completely originating from the arachnoid. So this was probably an arachnoid leptomeningeal seeding, what we had here after 3 years. But you can also get seeding from a stereotactic biopsy, as in this case. This was biopsied, and then of course the tumor is injured at that time, and this patient then had seeding with that. So what I think is interesting at this point is that despite all I said, that surgery plus whole brain radiotherapy, we're now getting into the age of neurocognition and the effects of whole brain therapy. I'll leave that to many other talks. But the final issue that I want to, because Priscilla is not here, but Max already elaborated on that, we want to study tumor evolution, and this is just a very recent opinion from her, just a few weeks old. When we have a brain met, we don't really know what the relationship is to the original tumor, and I think the original tumor will tell us very little about what the brain metastases may potentially have if we have the right agents for treatment. So I think this is one of Priscilla's favorite slides, so I think I'm obliged to show that here because that is another important consideration also for Max. You want the tissue for basic science, so we have to give you the tissue. So to get guidelines, this is from a German guideline, this is also in German. I think they become very, very, very complex, and for the different treatments, surgery, radiation, and radiosurgery, and I think this is all the issues for surgery already mentioned: unknown primary tumor, and more metastasis than 3, good surgery, and molecular testing. So all this is relevant. The radiation oncologists even had one of these trees here now for individual tumors. So there's an individual decision tree for melanoma. We have a more simple surgical tree here. So primary tumor known, if therapy is possible, then surgery is a major part of the decision tree when we have limited cerebral disease. I just want to mention that increasingly with the failure of local therapies, not only do we see more brain metastases, but we also see more intramedullary metastases. This is part of the CNS, so it's also prone to develop metastases, and there are limits to surgery. Sometimes when patients come in a very rapidly deteriorating state, although never having known anything about that cerebral involvement before, or we have cases where, of course, this is a feasible, easily feasible lesion. But when you then look at the whole status of the patient, and the patient's in very bad shape, sometimes we should withhold therapy, and this patient died 2 days later. So, and this, I think, was a very benign decision to make for this patient. So I hope to have shown you in this sort of run through surgical aspects of metastasis, brain metastases, that yes, there are a lot of reasons why we do surgery: decompression of mass effect. We can establish diagnosis, which are sometimes very different from what we expect. We can get good local control with or without radiosurgery, with or without whole brain radiation. It is, in most cases, a preparatory measure for further therapy, and we can, of course, assess the tumor evolution over time in the course of the disease. So I thank you very much for your attention.
Thank you. Good morning, everybody. So we'll move to the leptomeningeal metastasis now. So as you know, the leptomeningeal metastasis is defined as a spread of tumor cells within the leptomeninge and the subarachnoid space. It can sometimes be also called neoplastic meningitis, or depending on the primary tumor, leptomeningeal carcinomatosis, gliomatosis, or lymphomatosis. And to assess the diagnosis, so we need to perform a brain MRI as well as a spinal MRI, especially for you, Marianne. And we need to do a spinal tap and to look at the cells, tumor cells in the CSF. So leptomeningeal metastases are not so rare. It affects up to 10% of patients with solid tumor. The median overall survival is limited to 2 to 3 months, so the prognosis is still very poor for this patient. And we do have only a few prospective clinical trials available. Treatment strategies include intra-CSF chemotherapy, systemic pharmacotherapy, and radiotherapy. But these treatment strategies vary a lot depending on the center. So we have this level of evidence in leptomeningeal metastasis, so this is really not a lot. We simply have no standard for the neurological examination, the neuroimaging assessment, the CSF diagnosis. We have no standard for no trial on the systemic treatment, no trial on radiotherapy, and only 5 trials on intra-CSF therapy. So this is really not a lot. But based on the data available, we try to define European guidelines within the European Association of Neuro-Oncology and the European Society of Medical Oncology. So these guidelines are for the diagnosis, treatment, and follow-up of leptomeningeal metastasis from solid tumor. So for the clinical evaluations we agreed to define some typical clinical features, which include headaches, nausea or vomiting, mental changes, gait difficulties, cranial nerve palsies, sensory motor deficits of extremities, coda equina syndrome, radicular neck, back pain. And what we propose is really to use a standardized neurological evaluation. Certainly we can for the moment use the Lano grid, which was proposed but has not been validated yet, so it's something that we have to do as well. For the imaging evaluations, the slice thickness should be 1 millimeter or less. The gadolinium should be injected at least 10 minutes prior to the acquisition of the images. And also it's very important to use a standardized grid. You can see here the grid was proposed also by the Lano group that we are trying to validate within the brain tumor group at the ERTC for the moment. And we also agreed for this guideline to define several subtypes of leptomeningeal metastasis. So, for example, because we believe that probably this disease is not the same as this one. We have the type 1, which is linear abnormalities. So just here, as you can see. Type B, which is a nodular leptomeningeal disease. Type C, which combine both linear and nodular disease. And type D, which can be a normal MRI or hydrocephalus. For the CSF analysis, we recommend that the samples are processed within 30 minutes after sampling. and also to have enough CSF volume to do the analysis. And for the interpretation of the results, we have defined the positive CSF by the presence of tumor cells, an equivocal CSF in case of suspicious or atypical cells, so in fact when we have doubt, and negative CSF in the absence of tumor cells in the CSF. So based on this, we also agreed that the diagnosis of leptomeningeal metastasis should be confirmed when it's confirmed by cytology or histology, and which define a type 1 for us, and or not, which define a type 2. So I will show you. So the sensitivity of the CSF analysis is not very good at the moment. So we have several, so we try to improve, in fact, this sensitivity. We can use these tubes, in fact, with fixator to keep the cells for several days, and which could the CSF could be analyzed up to 3 days after the sampling, so it could be interesting. We also have new technique based on the detection of antibodies, and I think that several people in the room are working on this topic. So maybe we'll have new data soon, I hope. And also we can detect in the CSF some genomic alteration, but the premise is that for the moment we do not know how to interpret this alteration. It could be also related to the presence of concomitant brain metastasis or blood contamination, so for the moment it's still a bit difficult. So to assess the diagnosis of leptomeningeal metastasis, so we have the clinical feature, the MRI feature, and the CSF cytology. And based on this data, we have defined within the European group a proposal to classify the leptomeningeal metastasis. So as we discussed already, so we have the type 1, which a confirmed diagnosis, so by cytology or biopsy, and the type 2, so we have no histological or psychological confirmation, and the diagnosis in that case can be probable or possible. In all cases, the patient should have a history of cancer, and the diagnosis will be probable in presence of both MRI feature, typical feature, and clinical feature, so with typical clinical signs for probable or only without typical clinical signs for possible diagnosis. And according to the imaging subtype, so we define also type A, B, C, D according to the imaging presentation. So for the treatment, we can use systemic pharmacotherapy. We have no prospective trials on systemic pharmacotherapy for the treatment of leptomeningeal metastasis, but several retrospective studies. And the best systemic treatment should be determined according to the primary tumor, the molecular characteristics of the tumor, or the characteristics of tumor cells in the CSF, and the treatment already received by the patients. We have, so I told you, this 5 randomized trial for the moment in leptomeningeal metastasis for the intra-CSF treatment. So here that we can see it mixed up a bit, solid tumor and hematological tumor. We have only this trial from Willem Boeckert and Martin van den Wendt on breast cancer, which is nice. So in fact, the LANO group has proposed a critical review of the endpoint and response criteria for this trial, and we observed a lack of standardization for the evaluation of response, and also several methodological limitations. Also, we have always long times for accrual, and all the studies are open label studies, of course. So I would like just to comment a bit this trial, because it's one of the most interesting performed on breast cancer patient only, which is really good, and patients were randomized between so intraventricular methotrexate plus systemic therapy, and if necessary radiotherapy to the clinically relevant sites, or only systemic therapy and radiotherapy if necessary, so no intra-CSF therapy in this arm. The main objective was the overall survival, and clearly it was not in favor of using intra-CSF methotrexate. But in fact, the assessment was performed only on clinical evaluation, and neuroimaging was not used to evaluate the neurological response. And also the trial was stopped a bit early. But I think the main point for this trial is also that we had a lot of Omaya revision, up to 18% in this trial, whereas we have 3 large recent cohorts of patients treated with intraventricular treatment, and the revision rate was only 7%, so it's a bit different. So in the limit, sorry, it's really complicated. So we do not have randomized trials that has really demonstrated that intra-CSF therapy is a very relevant approach for this patient and prolonged survival, but it's still used by a large majority in physicians in Europe. And we have recent prospective safety data that show a good tolerance of liposomal cytarabine. Also, the compounds routinely used for the intra-CSF treatment do not have a key role as single agent for the systemic treatment of the cancer, most of the common cancer causing LM. But new compounds are under evaluation, and probably we will have more data with this new agent soon. So intra-CSF therapy also has only very limited penetration into solid tumors, so only 1 to 3 millimeters, so we can not ask to do more than that. And also intra-CSF may be inefficient and even toxic in case of CSF flow blocks, so this is important to know. But we have a rationale for the treatment of floating tumor cells, and also a rationale for the treatment of linear, diffuse or ependymal spread. So we have these trials, which is now ongoing, and we have only one more patient to enroll, so we should have the result quite soon now, I hope. Maybe for the beginning of next year. So in this trial, so it's an ideal breast cancer patient, and patients are randomized between systemic treatment alone or systemic treatment plus intra-CSF therapy with liposomal cytarabine. So maybe we'll have more data also soon. So the role for intra-CSF treatment probably it can be useful, but in selected patients, not for every patient, and mainly in the presence of floating tumor cells in the CSF and linear diffuse or ependymal spread. But it should maybe not be a first option for patients with hydrocephalus who require a ventriculoperitoneal shunt, because of the risk of dissemination, or without a ventricular device, without the on-off option. About radiotherapy, we do not have any randomized trial, but we can use the focal radiotherapy to treat nodular disease or symptomatic sites, such as fossa posterior for the cranial nerve palsy, or the lumbar level for the coda equina symptoms. We also can propose whole brain radiotherapy for extensive nodular disease or symptomatic linear disease, or even coexisting brain metastasis. So cerebrospinal radiotherapy is not really an option for this patient due to the toxicity. And about supportive care, so as usual in neuro-oncology, the lowest dose of steroids as possible, and the shortest time also. Seizure should be managed with drugs that do not interact with systemic treatment. No primary prophylaxis as usual also in neuro-oncology, I would say. And also for the patient with leptomeningeal metastasis, we should not forget this option, ventriculoperitoneal shunting, that may relieve symptomatic hydrocephalus and can be very useful for patients. So we have defined this very simple decision tree. It's based, so first on the life expectancy, of course, and then we take into account the type A, so this is a confirmed diagnosis and this is not confirmed, so we have no tumor cells in the CSF, and here we have tumor cells in the CSF, to make it simple. And we also take into consideration concomitant brain metastasis and the extracranial disease, as we discussed. And here, so we have it's always, when you read it, you always type 1A, B, C, D. It's always start with the intra-CSF therapy and then the systemic pharmacotherapy and then the radiotherapy. And when you have a plus, it means that this is recommended. Plus in bracket means that this is optional, and minus means this is not recommended. So in conclusion, I think the main message for these guidelines is that we have to define several subtypes of leptomeningeal metastasis. We cannot consider there is only one type of this disease. And so that means that we need a personalized treatment for the patients, and management strategy should take into consideration the general and neurological age status, the CSF findings, neuroimaging findings, the absence or presence of solid brain metastasis and also systemic metastasis, the histology and the molecular status of the primary tumor and previous treatment. And also we recommend a standardized follow-up for this patient. Thank you for your attention.